great that people are here, and welcome to all the people who are going to listen to it later on recording. This is the monthly research and education meeting, and this time we're going to have the presentations from the winners of the PRF essay competition from 2023. So the essays are done in 23, and the presentations are being done today in 2024. The essays are open to all medical disciplines: medicine, nursing, occupational therapy, physiotherapy, and psychology. The idea was set up over 20 years ago by Tim Nash, my consultant colleague, who's now retired. And the Pain Relief Foundation wanted to encourage students to think about chronic pain because it's really not covered very well, or sometimes not at all, in the curriculums of the British of the UK universities, and probably that's the same across the world as well, to be honest. So all the winners receive £500, which is definitely good for their bank balances, and I imagine doing this presentation might be quite good on their CVs as well. It certainly should be. The Pain Relief Foundation is a well-recognised charity, and it's a proper competition. So as you'll see in the meeting, it's been a very high standard this year, as it always is. Okay, so the first essay is the presentation is going to be by Rosie Dale, and it's going to be about the current diagnostic and treatment guidelines and how effective they are for chronic pelvic pain, which is very interesting to us as a group because we run a pelvic pain clinic, and we run a pelvic pain management program as well. So it's very interesting. Rosie is a Leeds graduate, and as well as being interested in women's health, she's also interested in anaesthetics and paediatrics. She's a Leeds graduate medical student. So over to you, Rosie. If you want to put your slides up.
Hi, yeah, I'll just pop my slides up now. Just checking. Sorry, just having some difficulty trying to get there. I'll try that again.
I was just empathising with you, actually, because I actually don't know how this works. I know Alison, and Alison might be able to give you a tip because she's
yeah, I'm just going on the share button, trying to share a window, but my PowerPoint, and it's definitely up, isn't coming up.
It should allow you to. If you've got a problem, you could always just email them over to me and I'll share them for you.
That might be easiest. I just can't seem to get this to. Sorry about this.
Are you going to do that? Are you going to email them to Alison?
Yeah. Is it Alison?
Alison Bradshaw.
Yeah. It's just coming over to you now.
Oh, brilliant.
It's just the PowerPoint. Ignore the essay that's coming over with it.
All right, okay. And you'll just have to ask Alison to tell you.
Next slide, please.
Say next slide, please. Yeah.
Yeah, that's fine. Again, I'm sorry about this. It's just not coming up on my.
Oh, it's okay. I always think that when you say next slides, please, it sounds quite good. You know, it's
maybe quite professional.
Yeah, exactly. Yeah. This is when we discover that the Walton Centre email situation isn't as good.
Exactly the same.
Yeah. Oh well. So what we do with the I'll just tell everybody a little bit more. What we do with the competition is we ask people to send a summary with a couple of references, and then if we're overloaded with the essays, we can sort of hone it down a bit with the based on the summaries, and so we select from the summaries, and then the people who are selected who've got a selected summary, they then go ahead and do an essay. So it's done in 2 stages. And we did this because there's such a great potential for lots and lots of people to do essays when you open it up to all the disciplines. Oh, here we are.
Fantastic. Thank you so much. Okay, so my name's Rosie. I'm a University of Leeds graduate and currently in F1 working at Forth Valley Royal Hospital. It's outside of Glasgow, hence why I'm at work at the moment. So I did my presentation and my essay on chronic pelvic pain and how effective the current diagnostic and treatment guidelines in the field of chronic pain are. And could you pop it to the next slide? Thank you. So just a brief introduction and structure. So one of the reasons I chose to do this was that I'd seen it a lot in my general practice rotations and often felt like there wasn't a clear sort of resource or guidance on how to go about diagnosing and managing chronic pelvic pain. And it led to lots and lots of sort of these follow-up appointments and some trial and error, which can be useful, but also quite drawn out processes before people were necessarily referred to specialists. So it was quite a big topic. So I'll go through a background on some of the definitions and how common it is and causes, diagnosis, management, and looking a bit about how effective these managements are. And I've broken it down into sort of pharmacological methods, surgical, and then sort of some of the broader psychological, social, and complementary therapies that maybe aren't so widely used, but sort of coming into play. Next slide, please. So as Royal College of Obstetrics and Gynecology, or the RCOG, define chronic pelvic pain as pain in the lower region of the abdomen or pelvis lasting greater than 6 months. It's very common, affects 1 in 6 women in the UK, according to one study. And again, it's a very common presenting complaint in general practice. And I've just put a little diagram here just to show that there's a lot of structures in the uterus, and often there's more than one cause that can be contributing to chronic pelvic pain. So this could be part of the uterus, the bowel, bladder, pelvic muscles, but also coming into play these sort of psychological, social issues and certain risk factors that can predispose people to experiencing chronic pelvic pain. There's a huge range of effects on quality of life. It can have physical effects, can affect how people do their jobs, can have effects on sexual health, and social and more mental factors as well. And next slide, please. Next slide, please. Oh, thanks. Perfect. So I just created this little table because there is a huge range of conditions, and some of the most common being endometriosis, IBS, adenomyosis, and this also shows quite a few of the crossovers of symptoms. So things like IBS can cause constipation, diarrhea, bloating, but things that can also cause these symptoms are endometriosis, pelvic congestion syndrome. Pelvic pain features in sort of all of these, but other things such as more defining features such as PV discharge and pelvic inflammatory disease, abnormal PV bleeding and endometriosis, and then considering other things that are in the pelvis area like MSK related pain, lower back pain, which can also cross over with things such as pelvic inflammatory disease. I think it's important when looking at this is taking this over into like diagnosis and management, not always looking for one underlying cause of chronic pelvic pain. There might be more than one cause, and when treating symptoms and condition and sort of the effects on quality of life, it's just understanding that there's quite a wide range of conditions that can play into it. Next slide, please. So the main set of guidelines are the RCOG Green Top guidelines, which set out a structure for diagnosis of chronic pelvic pain. Really important is the initial consultation with a thorough history and sufficient time to express symptoms and impact on quality of life. And it's really important that people feel listened to and that their concerns are being taken in as, you know, a serious manner, as it can have quite a big impact on so many aspects of life. Examination, whether this is abdominal, pelvic, bedside tests such as swabs or speculum examination. And then RCOG suggests that there should be quite an early referral to a specialist. Usually this will be a gynecology specialist for further assessment, diagnostic tests or scans, such as abdominal scans, transvaginal scans, or any other scans that might be deemed necessary, or further blood tests. Specific conditions, you might want to consider other diagnostic imaging, or for instance, at the moment, diagnostic laparoscopy is the gold standard for things such as endometriosis. However, it might be that treatment can be used as part of diagnosis, trials of treatment which may improve symptoms and might remove the need for such invasive surgery. So next slide, please. So split management quite broadly into 3 categories, but there is a bit of an overlap, and often they won't be used in isolation. So that's medical and pharmacological interventions, surgical and psychological, social and complementary therapies. So next slide, please. So there's quite a few different pharmacological methods. Firstly, there's looking at symptom management for chronic pelvic pain. So things such as analgesia. This tends to be NSAID based, and there's some evidence suggests that this is usually the most useful form of analgesia. Oral contraceptives are commonly used for cyclical and dysmenorrhea type pain. These are often first line, but obviously there can be some contraindications. So things such as GnRH analogues can be used and are useful again when oral contraceptives maybe aren't tolerated. One study showed that women with chronic pelvic pain taking an oral contraceptive had 87.7% decrease in chronic pelvic pain compared to just a 12.1% decrease in pain in the group receiving only NSAID therapy. And this was done using sort of pain scores and reports on function in day-to-day life. Medications can also be used for more specific symptoms, such as antispasmodics for IBS type symptoms, in conjunction with sort of dietary measures. Next slide, please. So the RCOG and NICE guidelines have moved away from a more surgical approach, although it still can be useful in some situations. So RCOG at the moment only really suggests surgical management for cyst aspiration in very large fiber adhesion fibers, but also considering that surgery has quite a lot of risk factors in itself, such as blood clots. Not everyone is suitable for surgery, and surgery in itself is a risk factor for more adhesions. So often surgery is not used in so much of the early stages of diagnosis and treatment of chronic pelvic pain. Laparoscopic uterine nerve ablation and LUNA, one double-blind trial showed improvement in dysmenorrhea only, which is only one aspect of chronic pelvic pain. So it might not be appropriate for all people experiencing chronic pelvic pain, and it wouldn't be perhaps so suitable for lots of other symptoms. Just touching upon hysterectomies, which there was one study, I think I meant to include it in here, that showed that it did show some positive results for some women, but I think it was 25% of women didn't actually have any improvement or had worsening in their pelvic pain. So importance of making sure that people are sort of risk factor stratified and considering whether long term this would be management, but obviously it's further down the line and has lots of implications for reproductive health and again further possibility of adhesions. Next slide, please. So this was a part of the essay I really enjoyed writing, psychological and complementary therapies. Really important, often overlooked, but there was a study that showed that up to 53% of women with chronic pelvic pain were found to have moderate to severe anxiety, and 26.7% experience moderate to severe depression, which really shows the impacts of chronic pelvic pain on mental health, but how mental health can then impact into the way people experience pain. CBT is used by NICE for treatment of more generalized chronic pain syndromes such as fibromyalgia, but there is no specific chronic pelvic pain CBT guidelines, and there's minimal studies on the effects of CBT in the field of chronic pelvic pain. However, if we were to think about how it affects other chronic pain syndromes, it'd be really important to have some more research which looked into how chronic pelvic pain can be hopefully improved by CBT. So it's an area which could do with some more looking into. One really interesting trial showed that in a randomized controls trial comparing one group who did 8 weeks of yoga therapy versus 8 weeks of just NSAIDs alone for management of chronic pelvic pain, showed that there was a reduction in pain-related scores and there was greater relaxation achieved by those in the yoga therapy group. And when considering this as sort of perhaps not a sole management of chronic pelvic pain, but in conjunction with other methods, it's probably quite cost effective. It may not work for everyone's lifestyle, but it probably could be quite enjoyable and has shown to have some really positive results. So next slide, please. I'm so sorry. I've sent over the one that doesn't have the conclusion slide on, so I'll just read out the ones that I've got on my presentation that I meant to send over. So some of the conclusions that I came to during this essay was that it's really important to have an early referral to specialists for specific tests, and this can minimize distress during the diagnostic procedure and make sure people are gaining access to early management and treatment. Multifaceted treatments and managing both the condition with analgesia, medical or surgical intervention, whilst also making sure that psychological input is in place early on, particularly if people it's having a big effect on quality of life. And further research is needed for chronic pelvic pain specific conditions, interventions, such as CBT. It'd be good to see if there's any improvement on sort of the symptoms itself, as well as any psychological sort of side effects of having the condition, and that holistic approaches are really important in order to improve long-term outcomes and quality of life, as well as treating each individual with chronic pelvic pain and their own impacts on their own day-to-day life. And so next slide, please. So there was supposed to be a question slide as well, but this is just some references. So if there's any questions, that's fantastic. Oh, I don't know what's going on with my webcam there. I might turn it off and on again.
Okay, Rosie. That was really good.
I'm just going to turn off the webcam. Sorry about that.
That was really good. I really enjoyed it. I thought it was a really, really good summary, and this emphasis on diagnosis before you can treat something is so important in chronic pain, and it's so important that we don't just treat chronic pain as a diagnosis and then try and treat that. Does anybody have any questions? I'm not sure how you would show it. Would you perhaps put your hand up if you've got a question, or just speak without your...
Yeah, I think there's a couple of hands.
Is there? Brilliant.
Yeah.
I can't see them.
I think Alex was first with a hands up. I think if we go to Alex.
Thank you.
Sorry, I feel like I've done that a few times by accident. Thank you. That was a really interesting presentation. I was just curious, going back to some of the medication management, if there's been any notice of the shift in how women seem to be perceiving oral contraception as treatment now. It feels like there's a bit of a shift, certainly online, in people moving away from wanting to have that. So I'm just wondering if anybody, I don't know if you came across any information in your research or in your clinic about how you've been navigating that with patients.
Well, that's a really interesting question. Thank you. I'm not sure while I was doing this, there was lots that I came across, but certainly while I've been in GP practice placements, it's important to consider, I suppose, because oral contraceptives can have quite a lot of side effects, and some people can be sort of quite susceptible to side effects, and some people just don't feel like oral contraceptives are the right thing for them. And there have been sort of, I looked at a few of the other sort of like gonadotrophin releasing hormone analogues, which can sometimes be used as alternatives. But it'd be interesting to see sort of what other medication options that there might be for people who aren't too keen on hormonal methods, and whether that's a bit more of a focus on psychological and social and complementary therapies, or more of an analgesia based approach. I'm not entirely sure, but no, I didn't come across so much of it during my, when I was looking into the essay, but yeah.
Okay, thank you.
And Summit has also got his hand up. Summit, have you got a question? Sorry.
Hi,
Yeah.
yes, thank you. Thank you for the presentation. I just wanted to ask Rosie, did you sort of, are you aware there's another sort of guidelines for pelvic pain from European Association of Urology, and it goes into the diagnosis and the management in a lot more sort of detail about certain things. Because I believe the Royal College guidelines from 2012, if I'm not mistaken, or that was my knowledge when I last looked at it, not have looked recently.
Yeah.
But
Yeah, I was, and I've written quite a bit about them in my essay and talking about how sort of the EAU, sorry, talks about how important it is at the first meeting to look into how the importance of assessing psychological distress and mood disorders early on in the initial consultation, which I found was, they seem very, very sensible guidelines and understanding sort of beliefs around symptoms. So I did go into a bit of detail in them in my essay, but I think I decided to mostly focus on one set of guidelines just for the 10-minute presentation at the moment. But yeah, they certainly seem to be used in conjunction with the Royal College of Gynecology guidelines.
Okay, can you hear me? Yeah.
We've just got one other question, but somebody else has just got their hand up, if that's all right, John, or do we need to?
Okay, one more question. One quick question and answer.
I'll be very quick. It's thank you very much for your presentation. I just wondered, in your experience or through your presentation, whether you came across the Pelvic Pain Support Network and their work in terms of peer-to-peer support.
It sounds kind of familiar. I think I may have come across it as a web page at some point. It was a little while ago that I wrote the essay, so I'm not entirely sure I can remember all the ins and outs, but I do remember there was like a support group. Yeah.
Did you remember anyone signposting to support group within your general practice placement?
I actually don't. I'm not sure it was. I hadn't heard of it actually until I'd started writing this essay. So perhaps there needs to be, some more signposting early on in general practice, and some more sort of knowledge about it from people who are working, if that's sort of like nurses and GPs in general practice, and in sort of gynecology specialist clinics.
Yeah, I think you're right. That's a really great presentation. Thank you.
Thanks.
Okay, well, thank you very much indeed, Rosie. That really was a great presentation, and thank you for the questions and the excellent answers that you've given. We have to say goodbye to you, I know, because you won't be here till the end, and
unfortunately, no, I would have loved to have stayed and listened to everyone's presentations, but I'm sure they're fantastic. Oh, and I can watch the recording, so
you can watch the recording. If I'm sure the Pain Relief Foundation, in the form of Lorraine, will be transferring some money over to you, and you just need to contact them for the rest of that. If that's okay.
Yes, that's perfect. Thank you so much, and it was really nice to meet you all.
Okay, well, good luck.
That's the knock on the door. All right, thanks so much. Bye.
Bye. Okay, so the next presentation is going to be from Jess Dudley, and Jess has recently graduated as a medical student from Leeds, and has a professional interest in chronic pain and palliative care, as well as traditional Chinese medicine. And she's going to talk about traditional Chinese medicine and chronic pain management. So over to you, Jess.
Thank you. No, thank you for having me. And sorry, I'm on someone else's Teams account, so apologies for the confusion. I will just share. Is that?
That's fine, yeah.
Oh, fab. And is that coming up okay?
It is. It's clear.
Perfect. So as I said, good afternoon. Thank you for having me. My name is Jess Dudley, and I'm a recent graduate of Leeds Medical School. I'm currently working on a frailty ward, and I've got a big interest in frailty and pain management. And today I'm going to present a summary of my essay in traditional Chinese medicine and its role in chronic pain management. So, as I'm sure you're all familiar, pain is an inherent part of the human experience. One way of characterising chronic pain can be pain that endures beyond a reasonable period of time for tissue healing to occur. Chronic pain is a life-altering condition and it can exact a toll on patients, including financial, social and psychological effects. A meta-analysis of chronic pain found approximately 28 million adults are affected by the condition in the UK, and moreover, chronic pain has emerged as one of the leading causes of disability worldwide. And as our population ages and develops more comorbidities, the burden of chronic pain continues to surge. So throughout my medical education, I've had the privilege of witnessing the remarkable effect of traditional Chinese medicine in the management of chronic pain. My interest began in third year when I undertook a course on the basics of TCM. We studied the principles, theories, and many different forms such as acupuncture, herbal medicine, and massage therapy. Following this, my interest remained, and I chose to undertake my medical elective in the Himalayas, where I was really lucky to see alternative forms of medicine where they're routinely practiced. I spent time with an acupuncturist and was really lucky to witness firsthand the transformative relief it provided to farmers suffering from chronic pain due to the intensity of their work. These experiences inspired me to write this essay, and as such, I want to explore how, despite the advancements of Western medicine when treating chronic pain, there are of course weaknesses, for example, tolerance and addiction, underscoring the need for perhaps a more holistic approach. Furthermore, I want to explore the potential roles of herbal medicines, diet therapies, and acupuncture alongside Western medicine. I believe this integration could ultimately offer patients a broader and potentially more effective approach to their pain management. TCM is a holistic system of healthcare that's evolved over thousands of years and is deeply rooted in the principles of balance and harmony. It considers the body, mind, and spirit as interconnected aspects of an individual's health. TCM practitioners employ an array of diagnostic techniques to gain an insight into an individual's health. These techniques include pulse examination, tongue analysis, and most importantly, the patient history. This assessment allows the formulation of personalised treatment strategies that target specific imbalances of qi. Qi is a fundamental concept in TCM. It represents the vital energy or life force that flows throughout the body and is considered essential to life itself. When the qi is hindered or disrupted in its natural flow, it can manifest as pain or illness, both mentally and physically. And these disruptions can be triggered by a variety of factors such as emotional stress, physical trauma, or imbalances within the body. I just wanted to talk a bit about herbal medicine. It's a cornerstone of treatment for TCM and utilises many natural substances such as plants, minerals, and animal products to restore balance and promote healing from within the body. The TCM concept of individualised diet therapies actually aligns really well with our principles of Western medicine. Research in Western medicine has revealed improper diet can contribute to various diseases, including cancers. And a study from 2019 reported that dietary risk factors are responsible for more and more deaths each year, surpassing other risk factors now, such as tobacco use. One example I wanted to talk about is ginger. So ginger has been used in TCM for 2,500 years and has been used to combat muscle pain, reduce swelling, ease arthritis symptoms, and reduce headaches. One paper demonstrated that daily consumption of ginger effectively relieved pain in patients suffering from osteoarthritis, and further studies have agreed with these findings. However, as patients increasingly combine medications and herbal supplements, there's concerns regarding potential interactions between the two. Herbal medicines and their sellers are largely unregulated, and this can present safety issues. Some herbs used in TCM have been found to interact with medications. An example is St. John's wort. It's a supplement for depression, and it's one of the most taken herbal supplements in the US. It's known to induce liver enzymes and potentially reduce the effect of certain medications, or it can cause unsafe effects with others, such as serotonin syndrome. So we need a better understanding of the compatibility of herbal remedies with medications to develop safer treatment protocols. Furthermore, diet therapies do remain understudied. This is primarily because conducting high quality research is challenging and expensive, but also there's an inability to patent and profit from natural substances such as ginger. This does diminish the incentive for pharmaceutical companies to invest in such extensive studies. Therefore, the scepticism lingers around TCM because there's a lack of empirical evidence in comparison to modern medications. However, the World Health Organization acknowledges that herbal medicines form the primary basis of healthcare for over 4 billion people worldwide, and many of our modern drugs have their origins in traditional herbal use. 200 modern drugs in the UK are derived from plants. Ultimately, I think a balanced integration of TCM practices and Western medicine may offer comprehensive and effective solutions to address the complex needs of patients with chronic pain. I just wanted to talk about acupuncture as well. So this is a practice that's gaining popularity in the West, and it traces all the way back to 200 BC. At the heart of acupuncture lies the concept of stimulating the body's innate healing mechanism, restoring the balance of qi, and in the process promoting healing and pain relief. It involves the insertion of fine, sterile needles into specific points. Research has helped us understand the underlying mechanisms of acupuncture. It's believed that acupuncture's effectiveness may be attributed to the release of endorphins, natural pain-relieving chemicals in the body. This will reduce pain perception and promote a sense of overall well-being. As I said, acupuncture is gaining recognition in the West for its efficacy in alleviating various types of pain, including chronic pain, post-op pain, headaches, and neuropathic pain. A 2018 meta-analysis encompassing 20,000 patients across 40 trials found acupuncture to be superior to placebo techniques in managing various painful conditions. And this is now recognised in our Western medicine. In the revised guidelines issued by NICE in 2021, it now includes acupuncture as a recommended treatment option for chronic pain. It's also important to emphasise that acupuncture is considered generally safe. In conclusion, acupuncture has garnered recognition and acceptance in Western medicine for its benefits in pain management. And the table on the left, this just demonstrates how the acupuncture points are mapped into 14 main meridian channels through which the qi flows. The meridian channels are like a network, and they can be compared to the circulatory and lymphatic system in the modern anatomy. Each meridian has a specific number and acupuncture points meaning. And the table on the right just demonstrates the commonly used acupuncture points and what they treat for. So one example is stomach channel 36. That's located on the front of your leg, just below the knee, and that can treat digestive disorders, fatigue, and other illnesses. So I just think it's fascinating and quite amazing how TCM originated from a time without diagnostic equipment or pharmacological advancements that we have now, yet certain aspects such as acupuncture are now incorporated into our treatment guidelines today. There's a growing interest and recognition of TCM's potential in Western medicine, and a large percentage of that is aimed at chronic pain. Moreover, TCM offers a holistic approach that extends beyond symptom management. It allows individuals to strengthen their bodies through diet choices, exercises, and lifestyle modifications. It's a prophylactic approach to disease. I, of course, recognise there's a number of limitations to implementing this. I work in the NHS and it's a wonderful thing, but it's understaffed and under-resourced. And a more holistic approach would mean longer consultations, which is difficult. However, in the pursuit of chronic pain management, the integration of TCM practices into Western medicine does hold immense potential. And by embracing this approach, we can provide patients with a broader spectrum of treatment options that not only alleviates pain, but also enhances their overall well-being. Thank you very much for listening. Is there any questions?
Well, thank you very much, Jess. I really enjoyed that. I thought it was an excellent presentation about traditional Chinese medicine. I'm going to stick my neck out now and say that I think it's only a matter of time before evidence-based medicine supports traditional Chinese medicine as it supported many other unconventional therapies. It's just that at the moment, traditional Chinese medicine hasn't had the sort of the sort of interest, the research interest that a lot of others have. So having stuck my mind out and being stuck my neck out and being quite controversial, I'll ask any questions.
Nikki's got a hand up if you want to ask your question, Nikki.
Yeah, thanks. That was really interesting. As physios, lots of us have kind of dabbled with acupuncture, and certainly I did it for quite a while. But moving into like chronic pain, it's obviously something we're trying to support patients to self-manage this long term. So I just wondered, when you looked at the studies, was there like a set number of sessions that was recommended, or is this something that patients might have to think about like privately, because it would be something that they'd need to do like long term to keep the benefits? I don't. Yeah.
Yeah, no, from memory, a lot of the studies were over like 6 to 8 weeks. But then when I saw it firsthand, even seeing one like half an hour to an hour was having amazing effects on people. But I think this was when I was away. I think the environment I was in is just people working so hard. So I think part of it was just having half an hour of like laying to themselves, a bit of like mindfulness, and that was just quite amazing to witness, because people were walking out so relaxed and looked so much, and their pain was improved. But I think most of the studies, were over 8 weeks, 3 months and things. And as you said, I'm not too sure how much the NHS offers at this point.
I suppose it's like those trying to get sustained benefits, really, to make it like cost effective, isn't it? But no, it's really interesting. Thanks.
Thank you.
I think we've got another question from Anita. We've got time for one more. Oh, Anita, you're just on mute at the moment.
Sorry about that. I don't know if can you see and hear me okay now? Jess, that was a fantastic presentation, really interesting. I just wanted to say that recently I had acupuncture as part of my NHS treatment with physio on my Achilles, and it was absolutely fantastic. And I think it's brilliant that the likes of acupuncture is now being embedded into the clinical practice. I just wondered what your thoughts are about the differences between the traditional Chinese acupuncture in comparison to the Western medical approach. And have you experienced that between healthcare professionals who are trained differently?
Yeah. Oh, I'm so glad it worked for you, because it's something I do want to do in the future. So I think definitely Western obviously focuses primarily, is everything's very rigorous, and if you're doing it in an NHS capacity, I've noticed everything's very focused on safety. In general, it is very safe, but I think in lots of people who tend to do it here avoid things like the lungs and the spine, because they're the only slightly high risk areas. And people tend to, as I said, like the more evidence-based here, but it was very similar. There's also, I think, in where it kind of originates in China, there's also more forms that we don't use yet. So they use different needles. They can use heat needles, ones that focus on like movement. So the way you put it in, you can like move it around or up and down. So I think there's still lots that we haven't taken kind of researched as much, but they've got lots of different forms that we don't use yet. But no, it's definitely something I want to pursue further and get to know a bit better. But yeah, thank you so much.
Oh, thank you. It was a brilliant presentation.
Thank you.
Okay, well, thank you very much indeed, Jess. That was excellent. And now we're going to move on to our third presentation. The third presentation is by Esther. And Esther, the second-year medical student at Leeds Medical School, currently interested in radiology and pathology, as well as you will see, as mental health. And she's going to talk about managing mental health alongside chronic pain. Thanks, Esther.
Okay, great. I'll share my slides now.
Yes, they're fine. Yeah, we can see them.
Brilliant. I'll get started. So my presentation is going to be about how mental health and chronic pain are linked. So chronic pain is defined as pain occurring for more than 3 months despite therapeutic interventions, and it exists on a very broad spectrum of conditions. However, there are general patterns that can be observed in its global effects on an individual, And when I say global effects, I mean like how it affects the person as a whole, both socially and psychologically, not just medically. So patients with chronic pain are more likely to be diagnosed with anxiety and depressive disorders. Yet conversely, having a psychiatric disorder actually increases the chances of being diagnosed with chronic pain. And when I learned about this relationship, I thought it was really interesting and wanted to see if it was because the two were directly linked or not. So that's why for my essay, I explored the relationship between chronic pain and mental health, dividing it into social, psychological, and physical links. So I'll start by giving a brief descriptions about depression and anxiety, because they're the two disorders I've primarily focused on. So the most common psychiatric comorbidity to chronic pain is depression. And I created these little spider diagrams based on NHS guidance, and they show some of the most common signs and symptoms that are associated. Some important symptoms I wanted to highlight are things like avoiding friends and family, unexplained pain, and avoiding hobbies and interests. Depression is generally described as a pervasive low mood, and this is especially important to consider when treating patients with chronic pain, as it can be linked to an increased risk of suicidality. And in anxiety, it's a similar diagram. So some symptoms on here that I would like to highlight are sleep disturbances, feelings of dread, and tiredness. So anxiety is the second most diagnosed psychiatric comorbidity, and it's defined as a feeling of unease or dread in response to a perceived threat. And there are many overlaps in symptoms between anxiety and depression, and because of this, chronic pain tends to be linked to anxiety via the shared symptoms from being diagnosed with depression rather than having a direct relationship. That's something I found interesting. And then to begin with the first link, I wanted to talk about isolation, because when I read personal accounts from people with chronic pain, this was mentioned in pretty much every single one. It was a very common theme, and it was often mentioned that the people around the patient did not truly understand their experience, as they themselves did not have chronic pain, and this made the experience very lonely for the person. And there was also a lack of understanding on how their illness could present. Being capable of doing an activity one day did not mean that they were capable every day. And however, this was difficult for people to fully understand, and they would lose friends as a result. And this burden was added to by mental health comorbidities. People would feel less able to keep up with social activities, and it's harder to be distracted from the pain. So overall, the experience of chronic pain was lonely, yet it also prevented people from going out and socializing. And this links to mental health, because isolation is causative of worsened depression and anxiety. Both of these illnesses are very restrictive and also prevent people with chronic pain from socializing. An important thing I learned about was how being distracted helps to reduce the perception of pain. However, being isolated can increase a person's focus on pain intensity, and it creates a sort of like a downward spiral of increasing isolation, worsened mental health, and worsened pain experiences. Next thing I wanted to talk about was a psychological model called the fear avoidance model, and it describes how when normal pain occurs, it directs a person towards that pain to give attention to either like a threat or a site of injury that's currently occurring. So it acts as an alarm, and it's meant to be a safety mechanism to help the person to avoid further injury. However, this can continue to occur in chronic pain, and it can become harmful. When attention is directed towards the pain, the perception of intensity is increased, as well as its impact on the person's daily functioning. Constantly feeling endangered can also widen perception of situations that may cause pain, such as moving, and this will lead to further avoidance. And this can be very debilitating and disable the person from functioning normally. This is linked to mental health again, because it's a common symptom seen in both anxiety and depression. catastrophic thinking is the common symptom. Basically, it's about being short-wired to go straight to the worst possible perception of a scenario, and experiencing catastrophic thinking can escalate the destructive nature of pain and worsen its experience for the person. And then this is a physical link I talk about. It's about ascending and descending, like neurological pathways. So there are lots and lots of different pathways, which I didn't go into the specifics of because it's very complicated, but generally it's divided into like ascending and descending pathways. And the ascending pathway is nociceptive, which means it processes harmful stimuli and identifies the type of pain we're experiencing. However, people with chronic pain may experience allodynia, which is the processing of non-harmful stimuli as causing pain, and it creates a perception of pain where there is no injury. And this may explain why people with the same chronic pain diagnoses experience variations in the type and severity of pain. And then the descending pathways are analgesic, so they determine the body's response to the pain. They tend to involve opioid receptors, which help diminish pain, stress, and emotions. And in some types of chronic pain, these opioid receptors are activated less, thus less inhibition of the pain. And other descending pathways are serotonergic and norepinephrinergic, meaning they involve serotonin and norepinephrine instead of opioids. These are closely related to the opioid system and are involved in the processing of anxiety and pain. Because they are so closely related, it is thought that there may be crossing over and physical links between them. And then I've got this graph here, which I sourced from a paper from 2021 about the physical anatomy of pain and suffering in the brain. And I thought it was very useful because it shows this relationship where when they're equal, there's no pain, but when they become unbalanced, you get perceptions of pain where there might be no injury. Yeah, and next slide. Then I also want to talk a little bit about neurotransmitters. So I've got serotonin and norepinephrine on here, and the systems involved in processing pain and anxiety and depression all utilize these same neurotransmitters. Increases in noradrenaline is thought to be beneficial to mood and mental health. And I'll talk about this in just a few slides, but SNRIs, which is type of antidepressants, are thought to have some analgesic effects because of this shared relationship. However, it's not the same as improving pain via treating depression. Rather, the crossing pathways of shared neurotransmitters create pleiotropic effects of the same drugs. And then the last link I wanted to talk about in this presentation, although I do have more mentioned in my written essay, is about sleep. So this is a really important link because poor mental health and increased pain both lead to impaired sleep. However, having worsened sleep worsens pain and increases flare-ups, as well as spontaneous pain episodes and hyperalgesia. It also increases anxiety and overall poor mental well-being. Pain symptoms are particularly linked to poor mental health outcomes when sleep problems are involved. And this is another example of like a downward spiral, as having increased pain and more poor mental health also increases worsened sleep experiences. And this may be because the processing of sleep, like the pathways I mentioned earlier, are quite closely related to the ones that process pain, anxiety, and depression. So I just wanted to talk about a little bit about supporting mental health and well-being. So I've got on here about, it's a very broad figure, but between 2 and 61% of patients have depression, between 1 and 10% have anxiety. However, generally these two are treated separately in the NHS, and there's a general need for like stronger communication and linking between these two services so that the person is treated as a whole and not two individual conditions. And then clinically, mental health can be supported with CBT therapies, the aim being to change behaviour that exacerbates catastrophic thinking, suffering and disability. However, this does not directly treat the pain and mental health problem, and CBT has generally been found useful in controlled scenarios. However, it's not been replicable in general practice, and as many as 50% of patients found no benefit in undergoing CBT. But this may more be due to the limited access to CBT trained specialists who can provide individualised treatment, and as well as the overstretching of staff who provide these treatments. And then something that was regularly mentioned as being positive in the accounts I read were support groups. It's about providing space to share common experiences, expertise and motivation. And this is to help reduce the isolation experience from having a chronic pain condition. However, there are a few barriers in this as well that prevent regular attendance, such as it being unavailable in areas of the country or flare-ups in the patient's condition and preventing them from going every week. And then the last thing I wanted to talk about was antidepressants, because I thought this was really interesting. So I talked a little bit about shared natures of certain neurotransmitters, serotonin and norepinephrine, and some studies I read found that there may be pain relieving effects in the use of antidepressants, specifically SNRIs and TCAs. SSRIs did not appear to be as useful from what I read, and some of the effects included reducing allodynia, hyperalgesia, and affective comorbidities such as depression. Although I should also mention that negative side effects have to be considered, and it's found to have limited efficacy in certain chronic pain disorders such as neuropathic pain and fibromyalgia. And it should also be mentioned that because chronic pain is so individual to the patient, even the better evidence antidepressants did not work for every single patient who was diagnosed with the same condition. So that means there's no guaranteed effective treatment with every medication, and it's something that needs to be explored more. So in conclusion, I've given a very brief talk about some of the links that exist between chronic pain and mental health. There's a lot more than even what I could have written about in my essay, let alone discussed in this presentation. And in general, the multidimensional nature of chronic pain must be considered when treating comorbid anxiety and depression, and keeping good mental health is very important in reducing the impact and intensity of chronic pain. Mental health can be supported via psychological and pharmaceutical therapies, and it's very important to acknowledge the patient's expertise in the management of their own condition. Thank you so much for listening.
You're very welcome, Esther. It was an excellent presentation, and I would just say that it's very, very unusual for me to see patients in clinic with chronic pain who don't also have psychological problems, which is nearly always in the form of anxiety and depression. And also, I think that you gave a very good scientific explanation of something that we see a lot of, which is the downward spiral. We all see this in chronic pain, but having a very clear explanation for why downward spirals occur, and potential, well, the difficulty treating the downward spiral was very interesting as well. So thank you for that. Do we have any questions? Perhaps just one question. Where are you, Alison? You were very good at getting identifying questioners.
We've nobody with the hand up at the moment, John.
Okay, well, okay, fine. Well, in that case, I'd just like to say thank you very much to all the speakers. It's been an excellent session, a really excellent session. I've enjoyed it a lot. I've actually learnt a lot myself. I thought all the talks were very highly informative, and they all had all the essayists had a real understanding of their topic, which meant that they could talk with real authority on their subjects, and that was very good. So thank you very much to the speakers, the winners of the essay competition. I'd like to also say thank you to Alison and Selena, who organised the research and educational meeting, not just this one, but all the meetings. Thank you very much indeed for that. And also I'd like to thank Lorraine and Julie from the Pain Relief Foundation, who make sure that the essay competition runs. They do all the stuff that makes sure that the essay competition is advertised, is properly marked, that we select people and everything. So they are the backbone of this competition. So, and finally, thank you everybody for coming, and thank you all those people who listen to it on record. It will certainly be worth listening to it on record. In fact, I'll probably listen to it again myself. So thank you everybody, and good luck. Okay, and good luck to all the students. It was excellent to see you. Okay. Bye-bye.
Thank you very much.